Thanks.
Well, good morning, everyone. My name is Bryan
Morning.
Trujillo. I'm the Regional Director of Community Health Improvement at Advent Health Colorado, which one of the hospitals includes Littleton Advent Hospital. So I'm going to share my screen here with our presentation. And throughout it, please feel free to stop me to ask any questions, any clarifying, just really meant for this to be more conversational. And throughout this presentation, I'll be starting out of what the hospital's health priorities are. We have three, but we'll focus on housing. I'll give a high-level summary of what the hospital has accomplished to date, and then I'll transition to new opportunities because we're embarking on a new community health needs assessment cycle that we're starting about a year earlier because we have a lot more significant resources that's going to help us develop more effective implementation strategies and one help us align in what's currently existing in the community, and then also aligning with our Arapahoe County's public health department. So love a thumbs up if I'm sharing the right screen. Beautiful. Thank you. Thank you. So I'm joined here by my colleague, Monica Knusel. And myself, we help support each hospital in their community health needs assessments and community benefit activities. In that, each hospital does have a mission director, and that mission director is primarily responsible for fostering and strengthening relationships in the hospitals. But Monica and I really help connect the dots and lead the community needs assessment because we standardize that process. We also oversee the community benefit investments by consulting with leadership and letting them know of what some of the things that we're seeing at the state level or through policy groups, so we can help advocate for change for some of these things. So I have a contact information here. I know that we're also going to share the slides after this, so do feel free to reach out to us if you have any other questions or if you'd like to participate in one of the action items that I'll be requesting for at the end. So if you're not familiar with the community needs assessment process, that is an IRS regulation that all not-for-profit hospitals are required to complete every 3 years in partnership with the communities to help identify the top needs after reviewing health indicators, and then after embarking on about a year and a year-long project in which various committees, both at the hospital and community, help identify what's possible, what can be measured, and what target populations we can affect change in. So each hospital, throughout Advent Health, they have two priorities that are standardized, and those are mental health and food security. But for today's presentation, housing stability is a top need that's identified in two Advent Health hospitals, Littleton and Avista up in Broomfield. So for the housing stability component, we have two primary goals. One of them is to focus on policy that help us to really connect our community members to stable housing and trying to figure out what the continuum of care looks like in each community so that we can train our clinicians into utilizing that platform, and then also try to figure out how we can better coordinate and align services and not duplicate what's occurring in the community. So what we spent in the past 2 years, rather a year and a half, is really focusing on updating our electronic health record to help support and facilitate referrals to specific community-based organizations. We've also focused on significant training for our clinicians, primarily prompting and data transfers to our other care sites. So we're not duplicating the type of interventions that we're providing our patients. So that means having equitable conversations with our on-house neighbors, moving away from any conversations regarding guilt and rather more towards intervention to figure out how we can really improve their care. We also have our activities broken down by year to see what's possible. But for Littleton, one of the phenomenal things that Jason O'Rourke has done, he's the mission director, is continue to participate in this group to once ensure that Monica and I are aware of what's happening in your community and continue to bring that information to our director of advocacy so we can identify which policies and which opportunities we have to coordinate services. I'll stop
Bryan,
there because I see Gretchen's hand.
Yeah.
Hi, Gretchen.
Hi, we're so glad you guys are here. Can you walk me through, like, when would your clinician intervene? Like, you have an unhoused person who shows up in your ER. Can you walk me through what are their points of intervention with getting housing support?
Yeah, absolutely. And I'm just writing the question to make sure that I hit all those points. So I'll go to my next slide here as well. The past 2 years, we've spent significant investments in an electronic health record by standardizing a social determinants of health questionnaire that's validated. So within that questionnaire, we're asking about housing stability. And there's 2 questions regarding housing stability. If we identify that they're at risk, then there are 2 potential avenues. They go to our case management, depending on the risk, because there's also a behavioral health, there's also other social risks. So depending on the total score of risk, a case management will take that on. If they are on Health First Colorado, then we are partnering with our regional accountable entities, and we're sending that information daily. And the regional accountable entity care coordinator then is responsible for managing that community member's care. And that's where the duplication of services comes into play. The care or hospital's care coordinator could be talking to the regional accountable entities, care coordinator to figure out placement. They may look at the continuum of care directory to figure out if they're already in a path of care, or those 2 care coordinators are collaborating and providing resources.
So what is that? So again, someone comes into the ER, they complete this questionnaire, or the nurse helps them complete this questionnaire as they're filling all the other stuff out, and then it gets sort of sectioned up. And if they don't have a RAE, then hospital case management steps in, and it's a conversation, and it's providing resources for that person before they leave. Like, they're stabilized, they got whatever wound they had taken care of, and it's here's some ways to get housing. Is that right?
Yes, absolutely. But the opportunity that we have this year is differentiating between the entry points. Because if someone is coming through the emergency department only, right now we're not administering that questionnaire. We could be identifying risks, but if they're discharged from the emergency department, they're not getting that level of care coordination. Whereas if they're coming through the inpatient side, if they're admitted. So one of the things that we're working on right now is standardizing those 2 points to ensure that we don't have any missed opportunities.
So in the ER, they're not getting the questionnaire.
They're not getting the questionnaire, they're getting standard resources.
Okay.
Okay. Yes. That's a great question. Thank you for that, Gretchen. Hi, Emily. I see that your hand is raised.
Hi, thank you. Yeah, just to kind of piggyback off of what Gretchen was saying, and maybe you already stated this, but what's the rationale for not completing that assessment in the ED?
Yeah, when it goes back to resources and the social determinants of health questionnaire, we participated. I'll try to give a brief summary here. So years ago, we participated in the accountable health community model and standardizing a social determinants of health questionnaire and providing navigation. We found that in the emergency department was not the appropriate place to complete that assessment because of the time. And then also patients were not being, from the feedback that we were receiving, they thought that that was not the appropriate time to be asking those questions when they're trying to manage a plethora of other health conditions. Also, when we would follow up with our community members, they did not activate the community resources that were provided, or we would have to start the whole process again because they are focused on managing their immediate health conditions. So that's why we standardized the process in primary care and then in the inpatient side. This year, in 2 of our hospitals in the region, we are embedding this intervention in the emergency department through our health equity work, because we are still, I know that it's a risk and we do need to provide resources. We just need to figure out our staffing model to determine when is the best time to have the conversation, but then also who is going to support that community member individually rather than just give them a piece of paper and discharge them. So we're figuring out those workflows to make sure that we're setting them up for success.
Thank you. Yeah, that makes sense that it would look like 2 different tracks. So yeah, I'd love to learn more at some point about what that ED track is going to look like once you guys flesh that out.
Yeah, would love to include you. And there is an opportunity to collaborate here. I'll talk about our steering committee for our community needs assessment process. And part of that, we hope to be able to provide quarterly dashboards as well of how well each of our interventions are doing, primarily with our social determinants of health questionnaire, because there is some sort of duplication with what's going on with, it could be a community-based organization and it could be a regional accountable entity. So our belief is that if we're more transparent with our data points, we can try to figure out and collaborate on what is the appropriate intervention. So the other goal that we just talked about is administering the social determinants of health questionnaire. It's a standardized tool that's embedded in the electronic health record. It's also part of the social health information exchange interoperability component. So again, right now it's set up that if we have a community member that goes to Denver Health or goes to Littleton or goes to Intermountain, that is being sent to the health information exchange. The race can see it. The hospitals, in theory, if they're subscribed to that interoperability functionality, they can see where the assessment was completed, which emergency department or inpatient department they were discharged from, and what type of intervention or resources that were provided. So we spent the past 2 years standardizing the data, and then also contracting with United Way 211 to help us provide validated resources monthly. Those resources are being provided directly to our electronic health record platform. So as our clinicians are identifying social risk, then they can match resources based on the community member zip code or other programs that they're receiving care from. And then that resource summary then becomes part of the patient's record. So it could be viewed by other clinicians. So again, we're not duplicating interventions. So those are Littleton's 2 goals relating to housing stability. We recognize that there's a lot of opportunities to align and then also strengthen what we're measuring within our outputs. So that's why I want to transition over to the community health needs assessment process. But before I do that, I would love to open it up for any questions or any other ideas that you folks might have regarding these 2 goals. Hi, good morning, Carrie.
Good morning, Brian. Thank you so much. This is very interesting, and I know that a lot of us have been dialoguing and working with Littleton Hospital, and we appreciate your partnership and a lot of work that happens in this area. I'm one of the county commissioners in Arapahoe County, and my question, I really appreciate the fact that you all are beginning to see this connection between housing instability and the increases in the work that you have in your emergency rooms, and I would imagine across your entire healthcare system. So and I don't want to put you on the spot, Bryan, because this probably isn't your realm, but part of the problem that we're seeing here is that it's not necessarily the lack of being able to connect people to resources. It's a lack of resources. It's a lack of housing in particular, in particular housing at this level of this entry point of people that you are working with that are experiencing homelessness or people who are right on the brink of that. And I wondered, and I've just talked to a lot of businesses in our community that are really talking about potentially trying to figure out like how you actually get into some of the housing components of our community as well, not only for your patients, but for your staff, as they experience those high levels of housing cost as well. So like I said, Bryan, not to put you on the spot, but has your organization talked at all about potentially partnering with affordable housing projects and things like that that just really need resources at this point?
Yeah. Thank you for that, Carrie, for that question, Carrie, because I love that you're really highlighting an upstream intervention, and that goes to our first goal to figuring out what is really the hospital's role as an anchor institution in the community. What is the responsibility to ensure that the workforce is adequately staffed? But then through that, I'll start there because that's the one that I can speak a little bit more with confidence. Our human resource has been working on a fair market value rate to ensure that cost of living is competitive. The cost of living pay is competitive compared to one other health systems, and then also their primary residents. So that's a program that HR is fully committed to. And then this year there have been two rates that reflect that. For the policy side, that's something that we're most excited about because of the opportunity. Post disaffiliation from Centura, now as Advent Health Colorado, we have significant more resources and actual bodies. So now we have a director of advocacy. We recently hired Monica. We have myself. It seems like now we have a small army to really help us identify which policy opportunities and which housing projects would be most effective, and identify which funding resources we have at the corporate level that could be through community benefit investments. But that's one of the things that it's going to take us a little time to continue to build up. But we want to highlight it in our new community needs assessment cycle that's going to begin in about a month and a half.
That's wonderful news, Bryan. And I think you'll find that on this screen here, you have a whole host of people that are working on the housing part of this and will be happy to partner with you. And many times our affordable housing partners need 10, 15, even up to 20 different funding streams to make a project work. And so it's wonderful to know that you all are considering coming to that table. Thank you.
Thank you, Carrie. I appreciate it. Hi, Jim. Good morning.
Good morning, Bryan. Thanks so much for being with us today. And it's really great to see just in black and white that housing stability is one of your goals. Just to plant another seed a little bit along the lines of Commissioner Warren Gully's question, this group is also embarking on kind of hopefully a phase of coming out of homelessness for many folks, which is permanent supportive housing. And permanent supportive housing, as you may know, is for those folks who need housing at kind of below the 30% typically of the area median income. Those kinds of communities also require a lot of services. And so healthcare services would certainly be a part of that. And I guess I just want to plant the seed that as this group moves forward, I hope that we can have you at our table continuously to have those conversations about healthcare can be part of that solution as we look to those solutions to bridge folks out of homelessness into, you know, the more mainstream housing market.
Jim, and I appreciate you bringing that up from healthcare needing to be at the table, because also there is, from my perspective, there's a commitment and an obligation through our community benefit investments in needing that there's an X amount of the funding that's available through the hospital to help address these health priorities, but also it needs to fully align with what's currently existing in the county. So as we embark this year in this needs assessment, identifying what is the financial support that the hospital can be providing to continue to help drive this work forward. I appreciate you making that connection and advocating that. Just thank you for the invitation, really.
Thank you.
Hi, Julie.
Hi, Brian. Thanks for being here today. I'm Julie with Graceful Foundation and Cafe, and also representing Change the Trend. Brian, I was curious about your social determinants of health kind of questionnaire, and then your case management, and then sometimes passing on to regional accountable entities. Is any of that done through Homeless Management Information System, or is that all separate?
So the Homeless Information Management System, that's what we call the continuum of care. But right now we're, what we've done the past couple of months post this affiliation, and right now we are utilizing a new electronic health record, which if you've been through any change in technology in healthcare, it's pretty significant. So
Right.
Before this affiliation, we had all the workflows set up to do that. And right now we're building them up again. So what we've prioritized is that everyone is completing the screening regardless of payer, because we have two measures. We have the hospital transformation program for our Medicaid community members. And then we have that information gets sent to the RAIS if they're that payer. But for everyone else, we have the CMS health equity measure that is done on every community member. And then that's the one that we're building out. What is the appropriate intervention based on the total risk, and then the referral platform. So it could be Find Help, or it could be the health information management system. Right now, for the hospitals, we're in the process of hiring a patient experience manager along with other clinical roles. And then those two roles would collaborate to ensure that our care coordinators are trained in that data, and that we're able to sign those contracts as well.
Okay, thank you.
Hi, Emily.
Hi again. I'm going to try and keep my question kind of general, because I live in the behavioral healthcare space. I've been a correspondent with Inglewood PD since 2018, and I'm just in kind of a new role there, but have a lot of experience mainly with the ED entry point into healthcare for behavioral health needs. I'm just kind of curious how you guys see your approach to information sharing in this referral process, because again, living more in like the ED entry point space, one of the pain points for me as a mental health clinician bringing somebody in, and again, I know it looks different whether it's inpatient or primary care or ED, but just across the board, information sharing really becomes difficult with citing HIPAA constraints. Sometimes even in places where I wouldn't expect HIPAA to be an obstacle because it's emergency services. And that's an obstacle that I ran into a lot as a referring clinician, even wanting to get dispos on clients that, you know, I was the person who authored their mental health hold kind of thing. So just how do you guys see information sharing, whether it's through primary care or inpatient, but when you're making these referrals?
Yeah. That's a great question, because it was the ideal of us participating in Colorado's Social Health Information Exchange Project through the Colorado Health Institute. We provided funding and then a lot of man hours in building up the infrastructure. We're kind of on a holding pattern right now with the new contract through the Office of E-Health Information to figure out their data standards. But right now, we're really following Boulder health departments, information exchange standards to figure it out. Can we do a community HIPAA release dependent on the type of services that are being provided, so we can remove as many barriers as we can? Before we contracted with United Way to provide us just a raw information, we had contracted with Bertha, and they were helping us. They were helping us get that community buy-in, so we can send those referrals directly to the organizations, and they can focus on providing that service and then reporting the outcomes to us, so we can then share that with our partners. There was kind of a gap there because the Office of E-Health Innovation, they said that they were going to release this contract. So we kind of took a step back and are following. We're trying to understand honestly what the E-Health office is going to do and what they're going to recommend for data standards, so we can follow suit. Because what we learned through the office, through the interoperability through the interoperability work groups, is that whatever we were coming up with wasn't being adopted. So after spending about a year on these white papers, on these thoughts, then the eHealth office was going a different route. So we're kind of taking a little backseat right now to figure out what they're going to do, so we can then begin to advocate and implement that in our electronic health record and processes.
Can I piggyback on that, Brian? I'm not sure everybody on here knows, but in crisis services, we have a little bit of some wiggle room as responders and providers. When there's a crisis, HIPAA can be waived to some extent, so that we as crisis evaluators can kind of coordinate. So Brian, just keep training your hospital staff that they're allowed to release information to us. I think if you could keep doing that on the front lines, that would be incredibly helpful, because that is a huge barrier to our evaluators and to the folks providing case coordination in the crisis space.
Yep. And there is some, I think that's a topic that we have an opportunity. I recognize I only have 1 minute here, but an opportunity for scaling. There's an upcoming hospital transformation conference for all hospitals. They're required to attend, and their clinicians and care managers are also required to attend, to go over all of their measures. So behavioral health, social determinants of health, substance abuse. I think that if maybe we have a conversation with Matt Haynes, he oversees the state program, that could be a section within the conference, or it could be an offshoot, to continue to focus on education and not think through the barriers, but rather what the opportunities are, because we already are going to have the captive audience there, and we just have to keep reinforcing that message. But I'd love to take that offline, Gretchen, to see how we can get that throughout the system as well. Want to ask Michael, do we have 2 more minutes, or don't want to cut into your time?
You can go ahead, Brian, you're good. We got a little bit of wiggle room.
So I'm just going to briefly go over our community health needs assessment timeline, and would love to invite you to participate in our steering committee. I'll go over the commitments and then what we're hoping to achieve in the next 1.5 years. So, like I said, not-for-profit hospitals are required every 3 years to complete a community health needs assessment process, in which health indicator data is reviewed for each of our service areas, so we can help identify the top 3 or top 1, depending on capacity, resources, and other opportunities. And then after the top needs are identified, we transition over to an implementation phase, which is having conversations with our community members, having conversations with different councils and steering committees to determine how we can build specific objectives for each health priority. How can we measure it? And how are we going to focus on outreach and alignment of initiatives? So I want to show you our new, very high level timeline for how we want to begin this year's community needs assessment cycle. We want to begin it in about a month and a half, start sending out invitations out to our community members and community leaders to join our steering committees so we can start holding those presentations and start working on those plans. Then we want to take the rest of the year to hold those meetings and again review that data and figuring out what resources exist at the county and what is the hospital's role. All of this is meant to be done as a consensus initiative rather than this is what the hospital thinks we should be working on. It's meant to be a transparent process with significant community outreach so we get all of that input. So by the middle of 2025, that's when we have a hard date set to publish our needs assessment and publish the county's findings. I am happy to say that next week we are meeting with Arapahoe County with their public health planner because they're also going through their existing capacity assessment. So what we don't want to do is duplicate initiatives. We're going to have a conversation next week to figure out how we can align our timeline and then also complete this collaboratively. That's just best practices. And then by 2026, which seems far away, but I'm pretty sure if we take a slow blink, we're going to be there immediately. That's when we would have developed all of our implementation strategies. Housing is still going to stay. Behavioral health is still going to stay. Food security may or may not, but since that's rolled up into a social determinants of health initiatives, we'll see where that goes pending community input. What we do want to highlight is once we identify what the hospital's financial resources to invest in the community are, and then also our staffing model, that's where we want to continue to highlight what is going to be the hospital's commitment and what's going to be possible. So this is the part that I would love to invite you to join our community steering committee. So we would want you to be engaged through, it could be existing committees or council meetings. We definitely don't want to duplicate anything because we know that everyone's time is valuable. We have our other responsibilities, but anything that we can embed in existing work to go over community health needs assessment objectives, that's what we're hoping for. We would want to stay engaged for the next year and a half to really advise what are some of the best practices in helping develop these strategies, what are some best practices in outreach, and are there other voices or community members that are not at the table that should be. That's what we really want to highlight. There are two facets to this, the community steering committee and then the hospital steering committee. The hospital steering committee would be made up of the case managers, nursing, leadership, and community benefit and our mission to really help align and figure out what is the company's strategy and how can we help support what's happening in the community. And then we do come together in different opportunities depending on the topics or the data that is being reviewed. Or there were a couple of questions here that were more, I think, my clinicians, colleagues would have been a little better to answer. And that's when we would invite them to really get more details to figure out how we can develop our implementations plans. So if you're interested in joining the steering committee, please feel free to send me an email. We will share the slides out. Monica and I will then begin sending out invites. And if you also want to have a side conversation to talk about your schedule or talk about other ideas that you have to contribute, we'd love to set this up with you to make sure that your feedback is incorporated. Then briefly, we do want to develop a robust health equity plan to figure out what is the hospital accounted for and what do you want to see the hospital work in your community. So developing that health equity statement, developing the specific target populations is one of the things that we want to accomplish through this community needs assessment cycle. And then lastly, one very important activity is helping complete a community survey. Right now, we're in the process of finalizing a community survey broken down by health priority, highlighting that if they do complete that assessment, if they do complete that survey, it is private. And then also, more importantly, finding out if our community members are telling us that they're facing a specific need for a priority, how we can make that actionable rather than ending that survey with a thank you. So we're figuring out through those logistics. In this component, we would be requesting ideas and thoughts of how we can scale the survey to ensure that it's completed and also identify any financial incentives for our community members to complete it. complete the survey. So sorry for rushing there the last 6 minutes. I do appreciate the extra time. But once again, thank you again for the opportunity for Monica and I to be here and attend this. Hopefully this was helpful. If you do have any other questions and want to join our steering committee, please reach out and we'd love to have you.
On the topic of the steering committee, I just want to make sure I understand what you were saying about, being involved in existing committees, So for example, would someone from your team want to continue to attend this meeting is that kind of what you're talking about, or am I misunderstanding?
No, Tara, I think that's perfect. Yes, that's one of the examples.
Okay.
So if we're already all meeting here and if there's the opportunity to slice out maybe 15 to 20 minutes through a specific cadence where we dedicate time to the needs assessment, that would be ideal. It would be respectful of everyone's time. If it doesn't work out that way, then we can figure out other strategies.
Okay. I think we can talk at our steering committee about that and see, what a good cadence might be to have you be on the agenda. It looks like Carrie has another question.
Yep, and I'd love to also, after my meeting with Arapahoe County, also trying to figure out how our timelines align and figure out which meetings they're holding to, again, come up with a grand strategy there.
Great.
Yeah. I think I just wanted to offer up that Arapahoe County, I'm thinking of 3 areas that you might connect. You've already talked about the public health community survey, which I think all of you all will be probably hearing from our public health department on some of this type of work, community assessment, as well as Arapahoe County through Kathy Smith's department does do a housing assessment as well, which could be a very helpful tool for you, I think, in the future as you're looking to your workforce housing and such. And then we do have a homelessness coordinating committee that many of us are also involved in that. So having somebody at that table, I would say would connect you to a lot of community. We have about 120, 150 different organizations in that group as well. And all of that aligns really with the starting work that Tri-Cities has done and really launched the rest of us to start working on this type of work. So
thank you for those connection points. We definitely want to make sure that we're connected there and leverage that. And again, to the last point, if there's already these surveys that are going out, there's no need for us to duplicate it, and then just really ensure that we can either develop more or path through one of the things that we spoke about with data sharing is figuring out how we can also get that information in a respectful way.
Thank you so much, Bryan. Really appreciate your presentation, really helpful and great to hear what you're working on. Thanks for being here, and you're welcome to hang around, or if you have other things to get to, you can take off and we'll see you again.
Wonderful. Yeah, no, I've dedicated time to this, so love to hear the other initiatives that are occurring.
Yeah.
But thank you again for the invite.
Thanks. All right, next up we have Mike with our action plan progress update.
Yeah, thank you. Good morning, everybody. If we haven't met, if you're newer to the call, my name is Mike Sandgren. I am serving as the Tri-Cities Homelessness Services Coordinator in a role overseeing the implementation of the action plan that this group has put together over the last several years. If you're new to the call, I will also share that today is actually my final Tri-Cities Homelessness Policy Group meeting. I'm going to be ending my time in the Tri-Cities coordinator role at the end of this month, and so this will be my final presentation. What I'm going to do is I'll walk through my typical slide deck, and I'm just going to highlight really the projects within the action plan that are still unfinished, which will really kind of form a summary of the projects that I'll be handing off to my successor in the role. So I'm going to share my screen here. If it comes, can you all see that?
I think it's going.
Yes.
There it is.
It's coming. Okay, perfect. Perfect. There's a new feature. It looks like PowerPoint can present directly to Teams. So I'm trying that out for the first time. So this will just, like I said, walk through our year 1, year 2, year 3 goals of what's been accomplished, what still needs to be accomplished. So as you can see here, I'll just highlight first, increasing local government staff capacity. We've still scored this project as in progress. Have gotten some good input from the staff, and I think we've seen a lot of steps happen in more of an organic capacity around kind of one-off trainings and things like that. But I think this action step could be done in a more kind of coordinated way moving forward. Second is creating a welcome home community engagement program. This is a step that we've really tried to build a work plan to integrate it into another step, specifically around landlord engagement, and have yet to land on the work plan that really is going to be given a green light to move forward. So this one's still marked as in progress. Third is supporting the Ready to Work partnership. This is a project that I would really classify as it's happening, but it just hasn't happened yet. We know that the Bridge House facility is in the process of they're starting their renovation. I'll talk a little bit more about that in a couple minutes. This will be launched by the end of the year, but has not been launched yet. One significant step that I think the group will be able to work on moving forward is the designation of a lead service provider under our family system. This is just a project that we have not dedicated time to yet, and building the work plan. So this will be a specific opportunity to focus on family homelessness in the coming months and years. Moving into year 2 goals, I'll highlight several that are still marked as in progress. The creation of a central navigation center. I think most of the folks on this call know this project is integrated into the Bridge House project. So this is, again, it's happening, just hasn't happened yet. When the Bridge House facility launches later this year, this one will be able to be marked completed. Piloting a safe parking initiative is one project that we're actually going to need a little bit of coordination in the interim between my end date and the onboarding of a new person. We've gotten some administrative point people from each of the cities to work with the Colorado Safe Parking Initiative to help coordinate their feasibility work for launching a pilot program for safe parking throughout the course of this year. And it'll be a goal in the next couple of weeks to just make a warm handoff between the CSPI representation, the county representation that's been at the table, and those point people from each of the cities. The promotion of shared housing, as well as strengthening outreach to landlords, are still marked in progress, as well as engaging local chambers of commerce, piloting a peer support specialist program, and expanding housing choice vouchers to families are all yet to be completed within the full scope of the action plan. Finally, in year 3, I wanted to mention the convening of local healthcare providers to discuss a street outreach team is still marked in progress. I think we've again seen some pretty healthy steps in the towards the implementation of this. Several, done in pretty good coordination with some of our partners at All Health, the mobile response unit, and then organically through the Stride Mobile Health Clinic that's come to the area is emerging as a strong partner in this work. Again, that's not a project that we've necessarily administered, but we're excited to see it launch in our area. So we're continuing to mark that as in progress. And then the one action step that's still to this date marked as just planned, which means we aren't necessarily working on it in a focused way, is the sponsoring of a feasibility assessment for permanent supportive housing. This really, I think this is kind of the bridge project between this action plan and into the emerging focus on the deeply affordable housing that this group has recently adopted. And so I'll be excited to watch this project be taken up and how explore how this group can participate in bringing some of those units to our area. So in total, we're still marking the action plan as 57% completed, 40% in progress, and 3% planned. So we'll be handing about 43% of this current action plan off to the next person in my role to take into the future. Gretchen, did you have a quick question?
Yeah, can you remind me the online platform for requesting? Is that through our website or is that something else?
Yeah, currently we're viewing that as the need help page on the website. It's kind of a streamlined way to access services, learn about services. We've developed that, we've launched that, we've had the Lived Experience Advisory Board review it. To be fair, there's not necessarily a capacity to like request, like I couldn't fill out a form, request services, and have a report generated for me or have anybody follow up. We don't have like the staff capacity to do that at this point. So that could be an opportunity to expand that particular action step, but currently it's the that project sits as the need help page on the website.
Well, and who's monitoring that?
We have a regional communications team that has a representation from all 3 cities that meets monthly. That's taking point on updating the website currently.
But they're monitoring anybody who's reaching out and needs help. And so that's why we're marking that as complete, because that is a platform for folks to directly outreach. Is that accurate?
Like I said, there's not currently a feature to make that, like, submit a form and make a request, but there's what we've tried to do is just streamline access for people to learn about resources and access them that way.
I don't think we should mark that as complete, because I
Okay.
think those are 2 different things for that specific action item, at least the way I envisioned it.
Okay. Yeah, I'm happy to make that adjustment. Good. And then I'll just highlight a couple kind of progress updates before I wrap up and open it up for questions. I know we're trying to keep some time for roundtable this morning. I did want to highlight that the role that I'm in is transitioning. I've mentioned that, but I wanted to mention that the job is posted. The current hiring timeline runs as a goal of bringing somebody new into the mix by May. I think the position is open, will stay open for 30, 45 days, and then we're hoping to source candidates for the role, and then there will be an interview committee and interview process. And so if anybody knows of anybody who would be interested in learning more about the role, the position is posted. They can find it through all of the county avenues. I wanted to mention the Bridge House facility renovation. We heard an update earlier this week that Bridge House is finalizing their building plan. They've hired their contractor. That contractor's in the process of hiring subs for the project. And they're set to begin demolition on the property by April 1st at the latest. And then one encouraging update that we heard was that Bridge House recently received a commitment of $300,000 from the Anschutz Foundation to support the renovation. So we're seeing some private philanthropic dollars come into the mix to support this project as well, which is encouraging news. And then I just wanted to mention, I think I mentioned this, but safe parking feasibility. We've established a working group to develop the feasibility scope and analysis over the next several months. And we're working to hand the Tri-Cities representation, do a warm handoff for between Tri-Cities representation and the county and Colorado Safe Parking Initiative to engage that feasibility work over the next several months. So I will stop there. I'm going to stop sharing there. And then I just want to make one quick comment, since this is my last meeting. If you'll indulge me for 30 seconds, I wanted to share. I think I'm one of maybe 2 or 3 people on this call who were actually present at the very first Tri-Cities Homelessness Policy Group meeting. And I recognize, and it's not lost on me, that there are a lot of people on this call who have an incredible amount of asks, needs, issues that come across their desk on a regular basis. And I just want to say a word of thanks to all of you for making the decision to dedicate some of your limited resources, time, energy, talent, critical thinking to the task of responding to homelessness, to the task of serving the needs of some of our most vulnerable community members. To be able to watch the increase in capacity to respond to the issue that's come as a result of the work of this group over the last several years has been deeply encouraging. And I feel really confident that our region is better positioned to serve the needs of the vulnerable exponentially more than we were 5, 6, 7 years ago. And a lot of that is thanks to the work of a group like this. And so, and the leaders that are part of this group. So thank you all for the sustained focus, sustained attention to this issue. And I know that the work will continue even in my absence. And I'm really grateful for that. And I'm excited to watch it continue into the future.
Thanks, Mike. I'm going to jump in first before I let Sean talk and just say thank you so much for your service to the community and to Tri-Cities. You know, I don't think we would be where we are today without you. You have such good skills for bringing people together. And I think this group is a testament to that too, the great people you've brought together. So we wish you the best. And I'll let Sean talk.
Thank you, Mayor. And yeah, Mike, I think, you know, with your experience, you would change the trend. You brought just instant credibility, particularly with our nonprofit partners, and have been able to leverage that into some really amazing things and bringing in new partners. I've really questioned whether we would have Bridge House in Tri-Cities had it not been for the relationship that you built with that organization and bringing them in. Just your ability to take input from a very diverse group of people and perspectives and put that into action and then track that action for us has just been really impressive. I think that was the unknown, is will he be able to implement all the things that we want to do? And you've just gotten us so far along, and you'll be leaving big shoes to fill. But thanks for all your work, Mike.
Joe?
Thank you, Sean.
Yeah, I want to echo those comments as well, Mike. Just even thinking back to long before Tri-Cities started working at Wellspring, kind of doing providing services on the ground, and then helping to launch Change the Trend. Just you've had a tremendous impact on our ability in the Tri-Cities region to outreach to our homeless population. We're really in a better place because of it. So thanks for all the work you've done over the last many years.
So agreed, Mike. You will be missed like tenfold.
Well, thank you, everybody. Thanks for the kind words. It's honestly been a joy, and I'll look back on this past season of working on homelessness with a lot of pride, and it's been an honor to do it shoulder to shoulder with all of you.
Great. And don't miss the chat.
Enjoy your next adventure.
I was going to say, don't miss the chat, because lots of other people are saying nice things about you. So make sure you read through there. All right, we have just a few minutes left. If anyone else wants to say nice things about Mike, or if you have an update from your organization, feel free to jump in.
I think there's a going away party for Mike next week, right? On Wednesday, maybe?
I can jump in with that. It's Thursday the 21st, and it's going to
Okay.
be 11 o'clock at Littleton Museum. So we'd love you all to join if you're able to make it.
Yes. Please come.
Thank you.
Can you send the info on that or put it in the chat for us?
Like Julie's on
Yes.
it.
Thank you.
Thanks.
Okay. Anybody else have anything they want to share? No. Okay. All right. Well, thanks again, Mike. I won't make it to the party. Sorry. So I'm just going to say bye. And take care, everybody, till our next meeting, April 11th. I'll see you then.
Bye, y'all. Enjoy the snow.
Bye.
Thanks, everyone.